Hello everyone, welcome back to my channel. Today we are discussing part 2 of the second case in the ITO series. If you refer to the part 1 of the case 2, we discuss about a post-op patient who is a vascular patient. This is the theory bit for the same case. And we'll discuss about peripheral vascular disease. Peripheral vascular disease is a broad term. It can include peripheral arterial disease, peripheral venous disease, or chronic venous insufficiency, then varicose veins, deep vein thrombosis, and lymphatic disorders. So, peripheral vascular disease is an umbrella term. We have to be quite specific when we communicate. So, this patient was having peripheral arterial disease, and which included chronic limb ischemia. So, how you differentiate these is that they present with symptoms of lower limb pain, which is called claudication pain. It comes about as intermittent claudication. So when someone walks for a certain distance, they have pain in the lower limb, which is like cramping pain, and they have to sit down and stop. And this is a characteristic feature of the lower limb ischemia. Over time, this becomes chronic and it can lead to critical limb ischemia, wherein you have someone who has a loss of lower limb pulses or cold peripheries and loss of hair, nail changes, which is all leading to chronic arterial insufficiency. So these patients then have to undergo certain procedures to restore the blood flow to the lower limbs. Else, it can lead to debilitating conditions like amputation or gangrene. Now, when we talk about peripheral artery disease, what is a central counterpart to it? So, cerebrovascular disease, which is anything to do with your arterial supplying the brain, and coronary artery disease, which is to do with anything supplying your arteries to your heart. So, these two are the counterpart of your peripheral arterial disease. This particular patient we talked about had aorto-femoral bypass bilaterally because they had changes or atherosclerosis significant amount to the aorta and bilateral iliac arteries. See, when you think about the anatomy, aorta, common iliac arteries, then comes the external and internal iliac artery, then external iliac artery becomes the femoral artery, so which supplies the lower limb. So, because of the extensive disease, atherosclerosis, the aorta and common iliac arteries, it had to be a bilateral aorto-femoral bypass. So, both the limbs are affected here. If it is not this severe, we might think about restoration of blood flow via other methods other than the aorto-femoral bypass. Like we could go for stenting. There are other procedures like endovascular procedures like FIVA or TIVA. Let's talk about TIVA. It is transthoracic endovascular repair, wherein the segment of aorta is replaced with a graft, and the other is FIVA, which is fenestrated endovascular aneurysmal repair. So, for aortofemoral bypass, the reasons are atherosclerosis, and if they have chronic limb ischemia, if there's any trauma of the aorta and any iatrogenic injury, then we go for aortofemoral bypass. Here we use a conduit, which is a synthetic graft. The synthetic graft could be made up of Dacron graft or PTFE. Before we do any procedure, they would do a CT angiogram. So this is to check for the extent of the atherosclerosis or extent of the graft we need to put in this particular patient. And interesting facts about the procedure itself is that it involves clamping of the vasculature. So when you think about the segment which we need to graft, they clamp above and below that particular atherosclerotic segment. So that means if you clamp the infrarenal aorta, then your mesenteric ischemia is a possibility. And to some extent, the renal perfusion also can be reduced. So the clamping can lead to ischemia of the perfusing organs. This comes under one of the complications. And when they declamp, you have to declamp distally first and proximally second. Because if you think about it, when you put the graft in, it is basically has some air in it. I mean, when you put the graft, you don't want the air to escape into the central circulation, which is to the heart or to the brain or to the lungs. So you want it to escape into peripheral circulation, which is to the lower limbs, and get absorbed slowly. But you don't want the air embolism to occur quickly. So you would flush the graft before putting it in. But if you unclamp the distal one first, the air is going downwards, and then your circulation slowly unclamped from the proximal will start to flow downwards. The conduit, as we discussed, is made up of synthetic conduit. We do have natural conduits available, like it could be allograft, it could be xenograft, it could be autologous graft. So autologous graft is from the same, when you take a graft from the same person. So if I'm having the procedure and one of my vessels are used, then it is autologous graft. Classic example will be great saphenous vein, which we use it for many purposes to revascularize and as grafting purposes in vascular surgery. But the great saphenous vein does not have enough caliber and cannot withstand the high pressures which the aorta has to withstand, and that's one of the reasons why the natural grafts are not used. In the same way, allografts, again, you could use allograft which is from the same species. So another person could donate their aorta to me if needed. But that means that there's always shortage of grafts available. Xenograft is again grafts from different species, which could be other animals. But again, there's all sorts of problems with that. It could lead to graft rejection. It needs to be properly matched and all of that problems. So synthetic grafts, that's why came into picture. And the Dacron graft is the most preferable graft for aorta because it has good caliber, it can withstand tension which is exerted on the aorta. PTFE grafts are more malleable compared to Dacron graft, but they don't have that much of caliber. So they can be used for smaller vasculature, medium to small vessels like femoral or any other distal vessels, or AV grafting for dialysis. Here, this patient, the graft he was having is a Y-shaped graft because it has to include the aorta and also bypass the iliac to become the femoral artery. Complications of this procedure would be graft thrombosis, where the graft itself has developed thrombus, and the other could be infection and bleeding, which is in case of any other surgery. Especially for the vascular surgeries, you have complication of pseudoaneurysm. The other bit is the ischemic process, which we discussed to the specifically renal ischemia and mesenteric ischemia. Ankle brachial index is another concept which is important in vascular patients, especially in acute limb ischemia or chronic limb ischemia, where there is peripheral arterial disease. So here we check the systolic blood pressure of the ankle versus brachial. So that's why it's called ankle brachial index. It's a ratio. So the ankle is where you check the anterior tibial artery, which becomes the dorsalis pedis, and posterior tibial artery, both of these arteries, and you take the highest systolic reading that you get. This systolic pressure you measure using your Doppler instead of the stethoscope. So you check where you can hear the Doppler sounds when you drop your systolic pressure on your sphygmomanometer. Then similarly, you take the brachial artery, and this gives your index. Anything from 1 is your normal. Anything less than that is has an element of peripheral arterial disease. And you check this pressures while the patient is lying down, and you don't want the gravity to change your readings. Ankle brachial index also is very helpful to check your prognosis of which direction we are going if the mild peripheral arterial disease has become severe now. And also post-op, you want to check the ankle brachial index as well. I was a little concerned whether this, after the grafting, when you check this ankle brachial index, would this cause any pressure on the graft itself? But if you think about it, you're checking at the ankle level, and your graft itself can withstand a lot of pressure. There's no harm in actually doing the ABI, and it's relatively common practice. Another complication you could develop after a grafting procedure is anastomotic leak. So the graft you put in is basically side end to side anastomosis. So the graft end is attached to the side of the aorta, and similarly the graft end in the distally is attached to the side of the femoral arteries, and it's a Y-shaped graft. So it is this way. And your normal vasculature is still there. They wouldn't take it out. That is because any flow which is still patent to your normal vasculature would be beneficial to your lower limbs. Unless it's an infected vasculature, that's when they would take your anatomical structures, or else they'll leave that in, and your graft will anyways flow, and that will become your main source from there on. If there is any concerns of internal bleeding, or if there is any concerns of the perfusion of the lower limbs, then you would do a CT angiogram. So our particular patient, the HB was dropping in that patient. We needed to transfuse like 3 units over 2 days to maintain the HB. And the lower limbs were not showing any signs of reperfusion. To me, it looked as if they were same before and after the procedure, and we couldn't find any Doppler pulsations, which was the same case before the procedure. The limbs still were cold, and patient was intubated and sedated, so we couldn't check for any sensations there. So that's when we discussed with the vascular surgeons, and they wanted a CT aortogram and angiogram of bilateral lower limbs. One was to check for the perfusion. 2 was to check if there is any anastomotic leak because the HP was dropping. The renal functions were also worsening. This we would expect after the procedure for the reasons which we discussed. But when we want to go for the CT angiogram, it involves a contrast. This means that the further impairment of the renal functions. But this is the chances we take, because we could always put the patient on a filter, that was CVVHT filter, in the intensive care. But we cannot not do the scan for that reason, because it could mean that the patient could have a potential anastomotic leak, and that would be drastic outcome. So yeah, we went for the scan, and then because the scan did not show any anastomotic leak and it showed good triple vessel runoff, we were happy with the scan. And yeah, so the end of the discussion. So next time we'll come up with another case. Until then, happy learning.